for this presentation. And Dr. Hemant Thacker is an eminent physician from Mumbai with over 40 years of clinical experience. And his specialty is in general medicine and cardiometabolic disorders. He also consults in Bhatia Hospital, Beach County Hospital, and has his private clinic at Suksagar in Mumbai. And he has also been awarded various gold medals and achievements in his career. And he is principal investigator in more than 35 multi-centric international and national studies, and has published several papers and written chapters and articles that are in reputed medical journals. So, welcoming you both for this interesting session on insulin co-formulation in action. And over to you, sir and ma'am.
So we heard all the theory about the newer insulins, the newest insulins, the too soon come insulins, and the dreamt for insulins. From multiple times a day to once a day, to soon once a week, and dreaming once a month. We're going to now talk about clinical action. Insulin co-formulation in action. And let's look at the clinical epiphanies. These are our financial disclosures. And I'm going to talk about Mrs. Savita, 52-year-old female entrepreneur, like most entrepreneurs, not all, but sedentary lifestyle, comes for consultation with complaints of tingling in the foot, fatigue and lethargy. It's a challenge for her to adhere to the advised diet. She's concerned about her busy lifestyle, motivated to adhere to the physical advice to bring her diabetes under control, delaying insulin for so many reasons, and look at her labs. HbA1c 9.8, LDL a juicy 126, not so much of weight but still a BMI of 26, mildly anemic, 12 years of diagnosis of diabetes, moderately adherent to diet, history of GLP-1 RAUs the year back, stopped due to all the GI adverse effects, is on CETA, metformin, EMPA, father, mother, both with diabetes, mother with kidney disease. She's worried about initiating an injectable therapy and worried about the complications of uncontrolled diet. I want therapy, but I don't want insulin. Now, I would like to ask the next question. How do we manage this case scenario? Because of her wailing and moaning, would you like to add another OAD or to initiate insulin?
Yeah, so this case we all see in our practice almost every day, and we may be seeing many cases like this. So just with a show of hands before we start the discussion, how many of you think that we can add another OAD to this type of the patient scenario with a show of hands? Anybody thinks we can add another OAD and bring down the glycemic control and the HbA1c level to 7? So nobody agrees. So I think the audience is well aware of what is the situation. So we saw this lady who is already having diabetes for around 12 years now. She has a HbA1c which is 11 plus, and she also has very high glucose values, and you saw her post dinners are around 280 and all. So postprandials are very high, and she has a eGFR of 89, and she has a family history of diabetes with mother had CKD as well. So we know that this is a patient whom you would like to have a good control, and you would want to bring the HbA1c down to 7. And we know that we are targeting a more than 4 to 5% drop, which definitely is not going to happen with any of the OADs. So we know that if you add a subsequent OAD to her, for this lady who is already on metformin, who is already on a gliptin, who is already on a SGLT2 inhibitor, and we did see that she was tried on GLP-1, but unfortunately she didn't tolerate, and it has to be stopped. So this lady is the best candidate to definitely be initiated on insulin. We'll be discussing in the next few slides that which insulin would be the best. But we know that because if you try to add a subsequent OAD, you are maximally going to get a drop of 1.5. But the thing is that at this point of time, if you add another OAD, you will not get that much of drop because she's already having diabetes for around 12 years now. So you're not expecting that much of drop. Yes, this answer would have been correct if she would have been in the initial years of her diabetes, where that much of drop still would have happened, but it wouldn't happen even to that extent in this lady at the moment. And you can see the data is also there. The successive OAD additions does not lead to more drop over and above the 1.5% mark. And we know that our Indian guidelines as well as the international guidelines are very clear that after 3 OADs it's the right time to discuss. We understand that now we have so many options for the patient, and it's the request, as Dr. Chandra was also alluding to, that the patient requests us and we sometimes give up and we just tell the patient, okay, you continue for 3 months and that time never comes again. And the patient comes back to you with the complications. So this is absolutely the right time because it's already delayed. It's not that we are on time. The patient is already well beyond that time, but this is the time when we have to tell the patient that you're already on these 3 medications. If I add one more, think of adding even SU, nothing will work out for her because her HbA1c is way too high and she's beyond that range where she will respond to that level which we are expecting, and no way that OAD is going to bring her HbA1c down to 7. So we should definitely talk and tell the use. This is a very important point that what happens that many times if you are very busy or if you are seeing the last patient in the OPD and said, what did you do? See what your glucose values are not controlled, you didn't do the things well, that's why it has happened. So this should never be done. We should never use it as a threat. We should always tell the patient that this is going to benefit you and this is for your benefit. This is one of the treatment scenarios we use for diabetes. It's nothing that you have failed in anything. This is how your disease will progress. You have done a good job, you have controlled it for so many years. Now because it's not working, there is no fault of yours. This is the natural history of diabetes, and because you did everything so nicely, the things have been in control for so long, and now you have to see to it that you again keep it under control. This is how we should talk about insulin and never use it as a threat, because that leads to more of diabetes distress and multiple other problems for the patient. So now Dr. Thacker, now the Indian reality, we know that we do talk about insulin and we say to the patient, let's start. But what as per your thing, like when you are trying to tell the patient to start insulin, how best you convince and which insulin is the ideal for this type of a patient scenario?
I think Dr. Kalra has correctly questioned her to insulin. It is the million-dollar question that we've been trying to answer, how to put her or put the patient on insulin. Do it in any way you want. Humility, compassion, coercion, etc. Don't use it as a fright or as a threat. Having done that, what insulin are you going to choose? The Indian perspective, mind you, and I heard a few lectures before this, that 2 world capitals of insulin are in Asia. Why in heaven's name should we not look at our phenotype? Let's look at how our phenotype behaves. Diabetes develops at a younger age, progresses faster from pre-diabetes to frank diabetes. There's high levels of abdominal fat, increased insulin resistance, even at low BMIs, the thin fat Indian, and beta cell dysfunction occurs quite early and rapidly. Now, high carbohydrate diet is a common Indian reality. Whether we like it or not, from the mind to the tongue, to the plate which we have in front of our table, the starch study, 61 to 70% energy intake in Indians is through the carbohydrates present in diet. High carb diet leads to raised PPG levels. In this study, 350,000, mean age 55 plus minus 11, mean HbA1c 8.5 plus minus 1.8, fasting and post-lunch significantly higher. More than 83% of patients had a BP sugar of more than 160. Now, the postprandial phase in Indians contributes to more than 12 hours in a day. We are always eating. We are always in the postprandial phase. I came this morning, I met a few people, I had a cookie and coffee. Soon it was lunchtime. Then there was coffee with something else at 4 o'clock. So if you see here, the basal glycemia also, the PPG increment, which is the peak preprandial glycemia, and additional overall glucose in patients with diabetes, from basal hyperglycemia to postprandial hyperglycemia. Unfortunately, more than 12 hours in the hyperglycemic phase. So if this is the Indian prerogative, and if this is the Indian predicament, as we know, PPG is the problem. Do you think it is important to have PPG control right from the start, Dr. Kalra?
Yeah, absolutely. Because if you see, when a patient with diabetes comes to you, many times we see in our OPD that what the patient will do on fasting glucose value. They wouldn't have done a postprandial at any point of time. Or what they will do is they'll do one post-breakfast. But we won't know what's happening to the post-lunch, to the post-dinner. And they may be having a very heavy dinner, which is a very, very common scenario in few of the places in India, many of the places in India, I would say. And some people eat a brunch. So what they'll do is they'll eat a breakfast and the lunch together, which is a very heavy one. And then they have too much of postprandial excursion. So if you see, this is a very, very common scenario. Now coming to the control which we need, we know that the postprandial control is a very, very important factor. And if you see that when you talk about the initiation of only basal, we know that obviously when the patient comes to you, when their HbA1cs are hovering around 7.58, they have fasting higher, they have postprandials higher, you try to first say that we fix the fasting first. But most of the time the scenario you see in our country, because of the diet being very high in glycemic index diet, their fiber content in the diet is low, and also one thing which is there is the protein content in Indian diet is very low. So what happens that they'll have predominantly high carb, which is also high glycemic index carb, and they'll have predominantly postprandial excursion. So no matter we control with the basal insulin, but you will see that in our population the fasting comes down but the postprandial excursions continue. So as a result of which their propensity to develop complications continue. So what happens that if you see, we know this always, we have seen these slides, that HbA1c level which is either nearing the target or much higher than the target, the postprandial is a major contributor in our population. And when we try to control this postprandial only with basal, we are not going to achieve the target, because we are going to control the fastings, but we will not achieve the target of the prandial control. And there are studies like DECODE study and many other studies where we have clearly seen that if there is a postprandial rise or a postprandial excursions, they have independent association with diabetes complication. We use the term vascular failure. So what happens with postprandial hyperglycemia? There is a sort of a vascular failure. There is endothelial dysfunction, and these patients are more predisposed for cardiovascular complications. So that's another reason, and we have enough evidence from other studies as well that we have to control the postprandial along with the fasting glucose value to get a proper comprehensive control for our patient. And we do talk about many other factors now, glycemic variability. We know that it's just not the fasting and postprandial, it's the glycemic variability, it's the HbA1c target, and day-to-day variability, inter-day, intra-day. We talk about so many parameters now. So that is why it is very, very important that we control the postprandial hyperglycemia from the start itself, especially in a population like ours. It doesn't mean that we are just going to do the thing with the insulin, but it also means that we are going to talk from the scratch, talking from the type of the diet, the amount of fiber, the quality of the carb, and also the protein content. Because if you see, as I already alluded to, the protein content also in most of our patients' diet is abysmally low, and they will not even realize that. So that's what we have to discuss when we are talking about the glycemic control with our patients. So, and we also know that this is a usual thing. Like if you ask, and nobody will say that I'll not control both the values. Definitely everybody will want to target the fasting and the postprandial. And when we have so much of data now coming up, knowing clearly that postprandial control is even more important to take care of the vascular failure which can happen in these patients. So now, because we have already decided and the patient has agreed to start insulin. Now, Dr. Thacker, what insulin would you consider starting in this patient?
So now comes the crucifixion, where you decide and you start the right insulin so that all the goals that we planned are all met. What is the aid for insulin decision? Postprandial glucose excursion more than 74, the first choice would be a rapid-acting insulin. The second choice is, I don't want to discuss the 50-50. If it's between 40 and 74, premixed insulin can be used 30-70. Of course, the second choice would be the 50-50. And if it's less than 40, you could go back to basal insulin. Because as we discussed, basal insulin doesn't do much for the postprandial. So this value of 74 is taken by calculating the BP glucose excursion for the diagnostic cutoffs for diabetes. Now, let's see in the next generations what do we have. I'm going to look at co-formulations because you are looking at controlling both the fasting and the post-lunch. There's the biphasic human insulin, which has the following advantages, but it has limitations. The lack of mealtime flexibility, opportunity for better BP control, and lower hypoglycemia risk. That's a limitation. Then there is the biphasic analog insulin, PASP, single dose. The advantages can be increased once, twice, or 3 times. It has also limitations where it has an opportunity for better FPG control. But what I want to talk about is this marriage between insulin degludec and aspart. IDEC ASP. In the steady state, look from 8 o'clock, 8 hours onwards, to 24 hours. It can be given OD or BE. The dosing is with the largest meal and if required largest meals of the day. It also has better control of FPG. It has a definitely lower risk of hypoglycemia, lower insulin requirement. And when you lower the insulin requirement, the weight gain problem is much lesser. IDEC ASP is the world's only co-formulation insulin where ultra long-acting degludec, which we just discussed, 70% dihexamers, with rapid-acting aspart, 30%, again hexamers. And these two insulin components do not interact in the solution and in the subcute space, thereby retaining their individual properties. And the indices for the holistic choice of insulin therapy are extremely important. They should have lower hypoglycemia, they should have mealtime flexibility, should be simple, convenience of device, better quality of life, and cost efficacy. So when you add these two together, cost efficacy, all the above, to the efficacy of the drug, which is the cornerstone of therapy, you get IDEC as the prudent choice. Now, having given you this evidence, Dr. Kalra, what does the evidence say when you have to consider this co-formulation over a basal insulin?
Yeah, this is a very important question because as Dr. Thacker already showed that what is this co-formulation and how it stabilizes the glucose values for a longer period and obviously controls the glycemic variability and the postprandial excursions as well. But what is the benefit? Like we always discuss and we think that this will work better, but do we have the evidence? So we do have the evidence and we have ample evidence with it. So we know that if you talk about IDEC aspart, which we are discussing, this co-formulation, we know that we have seen it is efficacious. That's why it's being marketed and that's why it's being used and tried in so many patients. it is safe. That data we already have from the studies, and we have the real world evidence as well. And what is important in a patient with diabetes? What is the most important thing the audience thinks in a patient with diabetes you would look for? What do you want to finally do? You would finally want to definitely prevent the complications, but you would want to improve the quality of life. Because if you see 10-15 years back when we were students, we were not even talking about this much. Like, this concept was very less in our country. But over a period of time, we have realized that in a chronic disease like diabetes, quality of life is very, very important, because the patient has to live with the disease. So that's another thing which people have now tried to look for, and that's why we are going for safer and safer insulins. Because if a patient has too much of excursions, highs and lows, if the patient has too many hypoglycemias or hyperglycemia, not only it will cause problems with the complications and other things, but the quality of life also is disturbed. They might have to leave their jobs many times. We have seen patients resigning from their jobs because they cannot cope up with the insulin because they get hypoglycemia in the afternoon and they don't take their lunch on time. So we have seen all these problems happening with our patients. So quality of life is a very, very important thing. And one thing which our patients always want is flexibility. Though we don't advocate this flexibility to the patient, because we won't say that, no, you take it, okay, with the co-formulation we know that we have to give with one of the meals, but when we are talking about a basal deglutec alone, we do give that flexibility option, but we don't give it to the patient. We know that if it happens, it's fine, but we don't advocate, but we know that if it is there, even if the patient doesn't take it on time, it does still work and it will not cause any problem to my patient. Now, if you see the percentage reduction in the glycemic parameters, and if you try to see, this was one of the posters which was presented, and what they have tried to see in the percentage reduction, and they have seen that when you compare the deglutec, the IDEC aspart with the glargine U300 and the glargine U100, there is definitely a beneficial effect, not only with the control of the postprandial, but also with the HbA1c reduction. So you can see there was a much better HbA1c reduction. And we can clearly understand that because we are giving a bolus component and a long-acting component. So we are giving two different types. One is to definitely give a basal effect, control the excursions, and one is to control the prandial glucose value. So definitely they saw better. And the only thing is, what we would have thought is there would be increase in the hypoglycemia, but they did not find that. So they did not find that there was an increase or any significant increase in the hypoglycemia incidence, though there was a numerical number was higher, but the significance was not achieved. Now, this was again one of the meta-analysis which was done to compare the IDEC aspart hypoglycemia as compared to the basal insulin. So actually what they found that there was a reduction in the nocturnal hypoglycemia. So that was one of the beneficial things which was found, because when we are trying to give only basal, what we are trying to achieve is we are trying to bring that fasting down. Most of the times we will keep the target of the fasting blood glucose to 100 or less. Sometimes we'll keep higher for older patients, but we'll try to achieve that target. And what happens, sometimes these patients get more hypos, and as we were talking about, that these insulins were not actually peakless, and we do get some of the peaks actually. So when you talk about giving a prandial control with a fasting glucose and a basal control to the patient with IDEC aspart, they actually found that the benefit was there in the risk reduction for nocturnal hypoglycemia with the use of IDEC aspart. And again, they have tried to switch to IDEC aspart from glargine U100 or 300 on the quality of life. And again, they have found that switching was found to be associated with the improvement in the quality of life. And the reasons are definitely, if you get a more flatter profile, if you get less hypos and less hypers, and if you have less of the problems with the variability, the patient obviously will feel better, and it gives one-shot option with the good control, because initially we do start with one of the shots with the meal where the postprandial excursions are the highest, and then we can go up to 2 times also, because there is data with that as well. So flexibility, we know this, we already discussed that for glargine U100 we have to give it at the same time every day. We know that patients do never follow the same time, but that is what is the recommendation. And for U300 we know within 3 hours we have the flexibility, but IDEC aspart has to be administered with the major meal. So not that they can take any time of the day, because it has a component of aspart in it, so it has to be administered with the major meal. So that much flexibility the patient gets, and obviously they can just inject it and within 5 to 10 minutes they can have their food. So that is again a flexibility, because if the patient has to wait then again it gives a problem, and that also hampers many of the things for the patients. And also, if you have to initiate, it's very simple. So it's not that you have to follow this hard and fast rule. You might have to give a higher dose as well in some of the patients. But this is a very simple rule that you can start off with 10 units. You might like to start a bit lower also for 1 or 2 days. There's no harm. I have many patients who are very skeptical about hypoglycemia. You know that they are requiring 20 units, but the moment you write any figure beyond 10, they get panicky. So what we do in such patients, we just start with 6 units, 8 units on a single day. Tell them monitor for 2 days. Once they are okay with that and they feel that it is fine, nothing is happening, we increase. So there is no harm in doing a dose escalation, little bit slow, especially if the patient is a little bit panicky about hypo, or they would have seen any of their family members getting the hypo. I had patients who had their family members who had hypoglycemia because of not insulin, but because of maybe the wrong titration, and they were so much skeptical about taking it, and it took a long time for us to convince. So those patients, you can even go a little bit lower and then again increase the dose as per the glucose monitoring. And we have to initiate with the meal which is the heaviest, where the postprandial excursions are the highest. That's what we normally do with our patients. So the regimen is very simple, and also we have to see that we might have to split it, and it's not necessary that you have to split 1:1. You might like to give a little bit more dose in the morning and maybe lesser in the night. This is what we do, and sometimes some patients have a very heavy dinner and their post-dinner excursions are huge and the post-breakfast are not so much. So there you might want to give a more dose in the night and the lesser in the morning. So all that permutation combinations we have to do on a case-to-case basis. We cannot have a very fixed regimen for every patient. So if you, this was like if you see the patients who switched from different other basal insulins, like patients switching to IDEC-aspart from Glargine Blue 100 or 300, they found that almost a huge number of patients were very much happier with the IDEC-aspart as compared to the basal. And again we discussed this, the quality of life is better, the hypo-hypers are lesser, the glycemic variability is reduced, patient feels better, and their symptoms also come down, because some of them will have too much of hyperglycemia or excursions in the night, and they have nocturia which disturbs their sleep, and once it comes down, these osmotic symptoms are better, they feel much better, their sleep is better. So all these things add to the quality of life. So now Dr. Thacker, what are the practical aspects of co-administration with OADs? Like, it's very difficult. Sometimes the patient comes with 3 OADs, 4 OADs, and the moment you start insulin and take out many of the OADs, the glucose values shoot up. And they say, oh, this is not working. And patient also gets jittery, and then doctor is also panicking what to do. So how do you handle such situations, and what should we do?
So this is a brilliant question, because when you swim in the river with the sharks, you've got to learn to live with them and make friends with them. You can't take off the OADs. You want to switch all your mixes and premixes and unwanted insulins to give you the right dose. Now, let's talk about the patient profile for IDEC as initiation. Uncontrolled on OADs. So he's a virgin as far as insulin is concerned. You have to manage the need for safety. Don't let him taste hypoglycemia, because either he'll run away from insulin or he'll run away from you. And give him flexibility at initiation. Then the next group is uncontrolled on basal insulin. You cannot give him hypoglycemia. You cannot give him weight gain, but you can give him flexibility. And the need for safety. If you have an elderly, frail patient, hepatic impairment, renal impairment, fasting condition, and erratic meal patterns. A patient on premix insulin, OD or BID or basal plus, with poor fasting levels, recurrent hypoglycemia, need for flexibility. That's the patient. And a patient on basal bolus, unacceptable variability in sugars, recurrent hypoglycemia, a patient who needs flexibility. These are the profiles where I would consider IDEC-ASP. And the switching to IDEC-ASP from other insulin regimens. Let's look at switch from basal insulin. Basal insulin OD or BID, it's a 1:1. I take as OD or BD. Of course, the dosage has to be tailored in patients experiencing hypoglycemia on glargine 300. Premix OD, again it is 1:1. Dose could be split over the main meals. Premix BID, 1:1 dosage, again could split over the main meals and give IDEC as you need. Premix 3 times a day, the same total dose, split over the main meals with or without additional fast-acting aspartame. This is important. Now remember, 10 to 20% reduction in doses for those experiencing hypoglycemia or whose A1Cs are around 8 or less. Switching from basal bolus, twice daily, which is 1 basal and 1 bolus, same dose as far as the basal is concerned. Thrice daily, 1 basal, 2 boluses, use the same basal dose, BID. And 4 to 5 times daily basal bolus. Use the same basal dose, but use fast-acting aspartame. You can use aspartame, and at night use IDEC as, or you can use IDEC as BID. Remember, these are broad guidelines. They are not diktats. You have to tailor it according to your patient's requirements. Switching needs to be individualized based on careful consideration of the doses, especially the basal bolus doses, and here you need closed sugar monitoring. This closed sugar monitoring is during the switch, after which, once you are saving, then the monitoring could be usual. So IDEC as a choice for insulin initiation. I talked about it in the beginning. It has lower hypoglycemia, mealtime flexibility, it's simple, convenience of device, better quality of life, and cost effective. Most important is its efficacy. We would not consider any of the 6 above had it not been efficacious. With that, I asked my colleague to go back to the case which I presented and summarize.
So now we understood that this patient definitely needs insulin, and we also understood that this patient has a lot of postprandial excursions. We saw her post-dinner was to the tune of around 284, post-breakfast and everything was higher, and her HbA1c was very high. So we definitely decided that we'll give her insulin, and basal insulin alone would not be effective for this patient. So we also decided that co-formulation would be the easiest for this patient, because this patient does not want too much of problems with her insulin regimen. So that also she was very clear in the beginning itself. So what was done, that patient was definitely advised about lifestyle modification, which has to be done for every patient at every visit, because many times after 10 visits, if you ask, the patient will sometimes tell, like a few days back one patient told me, "Doctor, I was following the diet because you used to tell me, last visit you didn't tell, so I thought that is not to be followed anymore because you are starting insulin." So these are all the concepts which are there in the patient's mind. So we need to talk at every visit about that. Then patients, the metformin, the SGLT2 inhibitors and the DPP4 were continued. Patient was started on the IDEC aspart, as we saw her post-dinner excursions were the maximum. So she was started on 18 units of IDEC aspart co-formulation in the night, and she did not complain of any hypoglycemias with that. And you can see her HbA1c, when like initially you can see it was 9.8, and after 3 months you can see it has come down to 7.2, and she has shown a good response. You can see the fasting glucose values have dropped down to 110, and the postprandial, if you see the post-dinner, which used to be 284, has come down now to 136. So we have seen a very good response, and we also have to see that, again I am stressing on the fact that we should never use insulin as a threat. It should always be used as a type of a treatment, and the conversation about insulin has to start on the day of the diagnosis of diabetes, not at the time when the patient has already come to you with this type of a picture. So when the patient comes to you the day one, they will say that don't start me on medications only, so we'll have to counsel, talk to them, and then the conversation of insulin has to come in, not as a threat, but we have to tell that this is how the natural history of diabetes is. It may be added over a period of time if you are not able to achieve the glycemic control. Not that it's your fault, but it may happen. Some patients it may happen earlier, some patients it may happen later. So we have to see how it happens and then we have to take a call, but we have to get these targets. If you are able to achieve on medications, fine. If you are not, we have better options for you, we'll give you. So this is how the conversation of insulin has to be, and never as a threat, because that will further add to the diabetes distress for the patient.
So you saw how we have now, we began with a Savita, but we now have a satisfied Savita, because 9.8 has gone to 7.2. The Wimbledons are going on. Tomorrow is the men's single final. But we hoped today that in discussing co-formulation, this mixed doubles team would be able to deliver to you the right victory with the right set of racket and ball in co-formulation. And we hope we have helped you, both Dr. Kalra and I, in delivering some semblance of logic into how we can use a better co-formulation, the only one of its kind in the world, to benefit our patients. Thank you very much.
Thank you.